I would like to introduce myself, as my background is most likely distinctly different from any of you sitting here today. I'm an interventional cardiologist, now retired from clinical practice. Hugo Carrero, the editor-in-chief of the European Journal of Translational Biology, identified me as the unknown Roger H. COLETTI when he wrote the foreword to my book, and I assume I'm unknown to most of you as well. However, I had a long-standing interest in chronic muscle spasm and sought to discover what kept the muscles in chronic spasm. I wondered if it was the muscle itself, a spinal reflex, or a central nervous system learned response. I followed the pioneering work of Janet Travell and David Simon in the publication of myofascial pain and dysfunction, but the actual cause of chronic muscle spasm was never fully elucidated. What follows in this presentation is a chronology of how I came to develop a treatment, the outcome data from the use of that procedure, and the ultimate insights into muscle pathophysiology with proposed theories of cellular and electrophysiological abnormalities. Additionally, I'm going to present today new unpublished EMG chronic muscle spasm findings with proposed theories of their significance. I need to make a critical distinction regarding types of muscle spasm. I identify three distinct types of muscle spasm: neurogenic as in post-stroke, acquired temporary as in exercise-associated muscle cramps, and acquired chronic muscle spasm lasting months to years. My focus in treatment was on acquired chronic muscle spasm. I did not do EMG evaluation on acquired temporary muscle spasm, and in retrospect, this remains a potential future area of inquiry. I believe it is likely that the mechanism of acquired temporary muscle spasm is simply depletion of energy stores needed for relaxation. I ultimately came to believe that muscle ischemia by at least two mechanisms is the cause of acquired chronic muscle spasm. These include membrane instability and hyperactivity of the postsynaptic alpha adrenergic receptor. Clinically, I was very comfortable assessing chronic muscle spasm and had tried multiple massage techniques to relieve spasm and pain in friends, relatives, and ultimately patients, but found that even the most aggressive manual treatments were seldom completely successful. Many years ago, an employee of mine suffered a stroke and had post-stroke calf spasm. A rehabilitation specialist used EMG guidance and Botox with marked improvement. This sparked my interest in potential use of EMG. I had noticed the brief mention of muscle electrical activity by David Simon, but its role in muscle spasm was not clear. I then purchased an ancient EMG device, ordered Botox, and started treating family members, friends, and ultimately a significant number of my patients who suffered from chronic muscle pain and chronic muscle spasm with a dilute solution of Botox that was EMG guided. The results were good, but full response took weeks, and my cost of Botox was never reimbursed. Looking for another less expensive medication, I found the work of David R. Hubbard Jr., who examined the use of various medications on muscle. He had identified the presence of spontaneous electrical activity as a key finding in trigger points and tried several medications to suppress it. His clinical trials with phenoxybenzamine, although not successful, seemed promising, and that ultimately became my starting point in developing my own treatment protocol. As I've come to learn, the science of electromyography is not without dispute and debate. Interpretation of the true nature of what is called spontaneous electrical activity, SEA, is not clearly agreed upon. What I found in my clinical experience utilizing an EMG device was that it was not the trigger points or the muscle end plate that needed to be treated, but any section of the muscle that had exhibited spontaneous electrical activity, or SEA. I discovered that SEA was not only the identifying signature of chronic muscle spasm, but appeared to be the causal agent as well. The association of SEA with chronic muscle spasm, and not just at trigger points, was the initial and most significant finding of my clinical research. Since the time of my original clinical research 15 years ago, there has been a broader understanding of what other conditions can lead to what was called spontaneous electrical activity in the clinical world of muscle spasm and myofascial pain. Motor end plate potentials and end plate spikes are terms describing features and possibly the basis of SEA. Apart from denervation, it has been recognized that certain muscle diseases and a variety of other conditions may present with fibrillation. However, there was no reported causal connection between these EMG findings and the presence of chronic acquired muscle spasm. What has become clear is regardless of the initiation of the SEA, the chaotic EMG presentation is a measure of the polarizations of skeletal muscle. In this video, the fluttering of the mitral valve is a result of the chaotic contraction of the left atrium in atrial fibrillation. Skeletal muscle in chronic spasm is actually undergoing a similar state with chaotic contraction of the muscle fibers in disarray. In the classic work, The Trigger Point Manual by Janet Travell and David Simon, there was a passing mention of an image of spontaneous electrical activity. David R. Hubbard Jr. had shown in 1976 that myofascial trigger points showed spontaneous electrical activity. As noted before, he went on to try various pharmacologic agents in the hope of suppressing the electrical activity at myofascial trigger points. His work suggested that phenoxybenzamine would be a likely agent, but he failed in his clinical trials to use it successfully. What I had not known until just recently was that Stephen Shannon had also tried to treat myofascial pain patients with phenoxybenzamine, but was ultimately unsuccessful. Working with a local sterile compounding pharmacy, a much lower concentration dose was recommended that a pharmacist found in an obscure journal. The dose was 1/10 of the dose David R. Hubbard Jr. used, which in fact had caused tissue injury in some cases. Phenoxybenzamine was known to take 45 minutes to 1 hour to form a covalent bond on the postsynaptic alpha adrenergic receptor. I tried that dose on myself and documented that it was quite painful. I then added lidocaine to the mix, as both had a pH of 3 and are compatible. Phenoxybenzamine is not very soluble, and any increase in the pH would take it out of solution and likely be ineffective. My use of lidocaine was primarily to decrease or eliminate the pain of the injection. This turned out to be a markedly fortuitous combination, as lidocaine eliminated the SCA immediately, giving time for the phenoxybenzamine to work. This allowed a sort of geographic mapping of the treated muscle, as anything still demonstrating SCA needed to be injected. When all sections of muscle demonstrating SCA had elimination of the SCA, the muscle could be considered fully treated. Ultimately, I added dexamethasone to minimize the inflammatory response, as the mixture was still a significant irritant to the muscle. The solution is made up as phenoxybenzamine 5 mg per ml and dexamethasone sodium phosphate 1.5 mg per ml. Over the course of 15 years, I treated several hundred patients, injecting over 30 different muscles. The results of these treatments, based upon a retrospective patient survey, was recently examined and demonstrated statistical significance. I realized that the results of my clinical research needed to be more readily available and more user-friendly. I maintain a website, CMECD.info, as a teaching tool for physicians, but it is a bit awkward to use, and I thought a book in hand would be more useful. In my preparation for the book, I had requested use of several of Professor Carrero's photomicrographs. He wanted to see my proposed use, and after reviewing the initial draft of my book, insisted that I make my work more readily available online, with one article regarding theory and the other demonstrating the practical aspects of my treatment protocol. I guess he thought my book and the findings were unlikely to achieve a widespread distribution and would most likely not make it on the New York Times bestseller list. He treated me as a complete novice I was to scientific article publishing. I had published a dozen abstracts on my finding in Muscle and Nerve, but no complete articles. Multiple rewrites were required before the articles were released for possible publication. The two articles taken together summarize both the theory and practice of my finding. The initial article is the ischemic model of chronic muscle spasm, published in the European Journal of Translational Myology. The second article is treatment of chronic muscle spasm-induced chronic pain treated with the CMECD procedure, published in the International Journal of Physical Medicine and Rehabilitation. The second article had been of interest to half a dozen journals for publication, but I wanted the primary reader of the article to have access to EMG devices. My book, entitled Chronic Muscle Spasm and Pain: Discoveries in the Etiology, Identification, and Treatment of Chronic Muscle Spasm and Resultant Chronic Pain, that was released last year, contains essentially everything I knew up to that time about muscle pathophysiology and its treatment. New information will be discussed today. Much of the content of my book, as previously noted, can be found also on my website, cmecd.info, which was set up as a physician teaching website. I intentionally received no royalties from book sales to keep the cost down and promote its distribution. In preparation for the second article, I assembled the results of a retrospective patient survey I had done years before and put the data into a spreadsheet for the first time. The full data set is seen here. While the data is not extensive, it did meet statistical significance not only as a successful treatment, but also supported that the length of time the muscle was in spasm did not affect the effectiveness of the treatment. Patients with chronic spasm that had lasted 10 years or longer had as successful results as those with months of chronic spasm. Diego Guinolin at the University of Padua took on the task of assembling the data and doing statistical analysis as a generous collegial act, which I am forever grateful. In a somewhat less busy slide, with half the data per slide, it can be seen that a relatively large number of patients had complete relief of pain lasting greater than 3 months, which length of time was used as a measure of long-term success. Virtually none of those patients ever had to return for additional treatment unless they found a way to recreate the obvious injury that had been responsible for the initial development of chronic muscle spasm. I followed a significant number of these patients as their cardiologist and would have been told if the pain had recurred. As can be seen in the second half of the data, a relatively small number of patients had no relief. Causes for that were unclear, but 2 individuals ultimately required back surgery and a few others had not gotten relief from epidural injections or any other modality. I did not provide pain medications for these patients. It is also notable that a significant number of patients were able to discontinue or at least decrease opioid and other pain medications. What is most exciting about the procedure is immediate and sustained relief of pain that accompanies resolution of the chronic muscle spasm. As one site is injected, it is not uncommon for the individual to recognize pain at another less severe site. The question, what is the cause of SCA, has never been clearly answered. In the world of myofascial release, it is generally accepted that SCA is only seen in the end plate or by other authors that it is simply end plate noise without clinical significance. The very large areas of muscle SCA that can be found with EMG examination of muscle in chronic spasm speaks against the concept that SCA is only at the end plate or that it is simply end plate noise. Current concepts now include debate over intrafusal and extrafusal origin of spontaneous electrical activity and is clearly beyond the scope of this talk and my knowledge. Looking for understanding of the etiology of chronic muscle spasm and SCA, I borrowed from my knowledge of cardiac muscle. It is known that diastolic blood flow in the coronaries is far greater than systolic blood flow. The presumptive mechanism is compression by myocardial contraction on the capillary beds restricting blood flow. Unpublished work I had done during my cardiology fellowship demonstrated that progressive suppression of the force of contraction with progressive doses of beta blocker medications led to a reversal of flow dynamics wherein the predominant flow was systolic. This work indicates that the severity of contractional spasm determines the degree of restriction of blood flow. It is known that cardiac muscle, when ischemic, can develop arrhythmias such as ventricular fibrillation. Ischemic myocardium has been shown to have membrane abnormalities affecting the sodium, potassium, and calcium channels that are energy dependent. It is also known that the chronic myocardial ischemia leads to the development of what is called hibernating myocardium. Subcellular elements are depleted, and upon restoration of blood flow, many months are required to repair and return to normal function. It was the work of Ugo Carrero, in particular the photomicrographs, that showed the skeletal muscle to be in a similar way to ischemic myocardium. He had identified hibernating skeletal muscle caused by chronic muscle spasm, but had not named it as such. His electrical stimulation techniques to relieve chronic spasm led to recovery of cellular elements with repopulation of mitochondria and muscle fiber recovery. Upon review of my work, he noted that he had assumed that muscle degeneration was a result of denervation, as was commonly believed, but recognized that the chronic ischemia as a result of acquired chronic muscle spasm was more likely the cause. The work of Ugo Carrero identifying the loss of mitochondria and muscle fibers with chronic muscle spasm needs also to be reimagined through the lens of tachycardia-induced cardiomyopathy. When atrial fibrillation gives rise to chronic rapid ventricular response, it is known to induce left ventricular myopathy that can be very severe, resulting in ejection fractions as low as 10 to 15% compared to normal greater than 50%. SCA on a single muscle fiber level is likely to produce an SCA myopathy. The constant excitation produced by SCA would likely lead to a state of energy exhaustion of the muscle contractile elements. This phenomenon, in addition to the contraction-induced ischemia, is likely to be an additional process responsible for the degradation of muscle and chronic spasm. Remember that even if there was not the constant barrage of excitation, it takes more energy for the muscle to relax than to contract. This phenomenon is borne out in cardiac muscle, where the initial result of ischemia is what is known as diastolic dysfunction, more simply known as impaired relaxation. The ischemia and subsequent SCA-induced myopathy that are then responsible for the progressive loss of mitochondria and muscle fiber elements. The ischemic model of chronic muscle spasm opened consideration for new and variations of current treatments. Heat-causing vasodilatation is a long-standing treatment for chronic muscle spasm. The potential benefit is better understood with this model. Compression techniques for the mechanical or contraction by electrical stimulation likely force some additional blood flow through the spastic muscle. The functional electrical stimulation used by Ugo Carrero may well have disrupted the SCA, at least temporarily, to stop the muscle contraction and allow at least temporary return of blood flow. It may have even acted as an electrical cardioversion of the SCA. This short, clearly non-professional video shows the SCA in a tensive fasciolateral muscle. The patient has IT band syndrome secondary to chronic spasm of the tensive fasciolateral muscle. When I was able to locate the muscle, there was clear and obvious SCA in a patient at rest. With multiple small injections of phenoxybenzamine, lidocaine, dexamethasone solution, the SCA is limited. This is initially the result of lidocaine because of its antiarrhythmic properties, and the long-term result is that of the phenoxybenzamine that takes about 1 hour to take hold. I propose that SCA is simply the result of chronic ischemia resulting from periods of acquired muscle spasm left untreated. This can result in membrane instability as one cause of SCA. I recently learned that prolonged ischemia in the skeletal muscle is associated with release of norepinephrine from skeletal muscle sympathetic nerve endings, and is thus another mechanism by which ischemia may be responsible for the SCA. Phenoxybenzamine non-selectively and irreversibly blocks the postsynaptic alpha-adrenergic receptor in smooth muscle, therefore preventing vasoconstriction, relieving vasospasm, and decreasing peripheral resistance. Alpha-1 and alpha-2 adrenergic receptors have been shown to be active in skeletal muscle with receptor-mediated vasoconstriction in skeletal muscles. Ischemia is known to increase neuronal excitability. It is also known that adrenergic receptors modulate motor neuron excitability. Thus, the effect of the phenoxybenzamine appears to be twofold. The first is that it has a long-term effect as an antiarrhythmic by blocking the effect of the ischemic release of norepinephrine that affects motor neuron excitability. In this regard, the characteristic SCA of chronic muscle spasm is likely in part, if not predominantly, due to the norepinephrine effect to increase motor neuron excitability. Secondarily, it provides much-needed vasodilatation to overcome the contraction-induced muscle ischemia that itself is in part affecting the motor neuron electrical instability. The immediate effect of a lidocaine that is used in the CMECD injection procedure is an antiarrhythmic, and likely the reason the muscle spasm is relieved immediately upon injection. Technically speaking, lidocaine inhibits cholinergic synaptic transmission with a voltage-dependent inactivation of EPSP amplitude through the membrane potential depolarization of presynaptic neurons. The SCA-induced tetanic contraction is aborted and blood flow can normalize. Phenoxybenzamine forms a covalent bond on the postsynaptic alpha-adrenergic receptor as a functional duration of action of 2 to 3 months while the muscle is developing replacement receptors. This 2 to 3 month duration of action appears to be sufficient for the muscle to mostly recover. Phenoxybenzamine non-selectively and irreversibly blocks the postsynaptic alpha-adrenergic receptor. Phenoxybenzamine forms a covalent bond on the receptor. It has a functional duration of action of 2 to 3 months while the muscle has time to develop replacement receptors. This 2 to 3 month duration of action appears to be sufficient for the muscle to mostly recover. The muscle spasm is relieved immediately upon injection and blood flow can return. Phenoxybenzamine compounded with dexamethasone is available from what was to me a local pharmacy when I lived in New Jersey that happened to be a sterile compounding pharmacy by the name of Miller's Pharmacy in Wyckoff, New Jersey. They can ship to anywhere in the United States overnight on ice. To begin with, you'll need an EMG device. Handheld devices are entirely adequate. I prefer those with a screen rather than those that are sound only, which are of a lower price. The cost per patient for Miller's Pharmacy is currently $120 per patient, and the cost of an EMG injection needle is $18. For those outside the U.S., phenoxybenzamine is available to any licensed pharmacy in the world from a company in Texas, USA by the name of PCCA, and their contact email is clientcare@pccarx.com. They will ship worldwide, and you then need a sterile compounding pharmacy to add the dexamethasone or add it yourself and add the lidocaine at the time of treatment. I treated over 30 different muscles. All were equally responsive. Care must be taken around the lungs not to drop a lung. Fortunately, there's characteristic sound on the EMG when you get close. So what are the primary targets? Of course, low back is the first, but piriformis is the second, as no other treatment really works, and it is a slam dunk. As I have taught others, localization for injection is simply butt crack top high, mid butt, and can't be missed. Recognize that a 3-inch needle penetration or more is required, and one must bury the needle in more generous butts. Any SCA found in that region has to be piriformis. Try to go medial and lateral to get it all. Remember, the sciatic nerve is right there, so go slowly. Neck is always a great target. I had one woman with post-surgical inability to turn left for 27 years, and 2 injections resolved the problem. The story is interesting as she required her husband to look left when she drove, but after his death had to stay in the right lane until treatment, which was fully successful, and there was no recurrence. This is the handheld device I use. Unfortunately, it is not currently available as a new model is forthcoming. I always use a 3-inch needle to minimize skin punctures, since some muscles in the back and piriformis require it. This is what is seen in normal muscle at rest. There is minimal baseline activity, but no significant action potentials. One does not need to be an EMG expert to understand the significance of the basic EMG findings. The first thing you would notice is what is called insertional activity. When the needle penetrates the muscle, you will hear and see some activity. Normally, the activity is very brief and stops immediately when movement of the needle stops. However, sometimes the needle sets off a train of action potentials lasting a few seconds. This is called increased insertional activity. The finding of increased insertional activity, in my experience, is associated with muscle that is not yet in chronic spasm, but is demonstrating some membrane instability, and may correspond to what may have been called latent trigger points. In any case, and most interestingly, insertions that set off increased insertional activity act like dry needling, and in some cases can cause the muscle to relax, even without the injection. I had a few cases of this sort when I would not inject anything without classic SCA, and the patients got better just from the attempts to find the non-existent SCA. Without going into details, discussion, and theories, just know that there is evidence that dry needling can reduce SCA, although not eliminate it. Multiple sessions may be adequate for treatment of chronic muscle spasm and pain, and EMG guidance has been shown to improve the outcome. The advantage of the CMECD procedure over dry needling is immediate relief and sustained effect with one injection. Return patient visits are therefore not guaranteed. For the primary care physician, however, this would be a blessing not to have to continually deal with the chronic pain. This video demonstrates the typical SCA with a chaotic appearance. This is what you see after injection, with virtually all of the end plate noise and other action potentials suppressed. It is similar to what you see in normal muscle at rest, essentially a flat line. A significant type of action potential is an MUP, that is a motor unit potential. Although I have recorded EMG signals for years, it was just recently that I had the opportunity to have an EMG expert identify an action potential that I mistakenly thought might be a fibrillation potential. This is a key finding in that it has never been reported either in trigger point literature or any description of chronic muscle spasm. The presence of trains of MUPs seem to be present in more severe chronic muscle spasm. These action potentials represent activation of a larger muscle fiber and presumed contraction. Constant contraction of larger muscle fibers that can be activated by an MUP help us understand how the muscle is kept in a state of constant spasm. This finding also ties into the theory that I had proposed as the ischemic model of chronic muscle spasm, as prolonged ischemia is likely to lead to membrane instability and spontaneous depolarizations. In areas that had been recently treated, voluntary activity increased the overall SCA, but no MUPs were seen. In areas that were not recently treated, voluntary activity gave rise to MUPs. In normal muscle, MUPs are activated by voluntary activity. Treatment with lidocaine alone also prevented the appearance of MUPs with voluntary activity. Suppressed SCA with intermittent voluntary contractions of increasing intensity to show that the muscle was still capable of contraction, but no MUPs were activated. In cases where there were MUPs associated with chronic muscle spasm, the early effect of the injection resolved the end plate noise and spikes, but initially the MUPs remained temporarily. This is a video of that condition with only MUPs. The most recent finding that appears to have clinical significance is shown on this slide. There is very low level of SCA that pales by comparison with that which I have shown you previously. It was associated not with a muscle that was causing active pain, but one that readily became painful with relatively mild use. My interpretation was that there was constant low-level activity that depleted the muscle energy stores, causing it to fatigue and cause pain with less than expected use. The next slide is the result of treatment of that same site. Associated with that treatment, there was improvement in the clinical symptoms. This finding indicates that there are levels of muscle instability that may benefit from treatment even though the marked SCA is not present. More research into this finding is necessary. There's a section in my book, and also found on the CMECD.info website, entitled Step by Step. In that section, I present all the details needed to begin using the procedure, as well as insights and cautions for each of the major muscle locations. As I noted earlier, I am now using a dose of phenoxybenzamine half strength than what I had used in the past. Hopefully, it will be shown that this dose is better tolerated and equally effective. The question you should be asking is why all of this has not been obvious to so many in the past. So much has been done to treat chronic pain and chronic muscle spasm, yet the simple finding of diffuse SCA is not common knowledge in the medical world. As it turns out, there has been a lot of research about trigger points, with a fair amount of conflict as to what the origination of the SCA. With all that highly technical approach, the broad findings were overlooked. The use of phenoxybenzamine was attempted in 2 trials with EMG guidance without success. This was most likely due in part to the very high dosages utilized that were up to 10 times my historic dose and 20 times my current dose. Tissue irritation and even tissue damage was noted. Diffuse spreading of the injectate was also not utilized. I was fortunate to have a local compounding pharmacy suggest a dose based upon a reference somewhere in the pharmacology literature that I have not successfully been able to trace. The primary reason I'm presenting my findings to you today is to provide you the opportunity given to few to relieve chronic pain without the use of opioid medications, with a simple and inexpensive procedure that needs to be done a single time for long-term relief. Some of my patients were able to discontinue their opioid medications altogether, or at least lessen their use, as I noted in the patient survey shown before. I provided no pain medication to any of the patients I treated. While it would be preferred to have a large clinical trial with substantiated results, the use of an FDA-approved drug with few known adverse effects to use in place of opioids should be relatively easy to defend. I hope the information provided in this presentation will increase the chance that you will understand this procedure, gain the satisfaction of relieving chronic pain of your patients, not to mention the benefit to your patients. Last but not least, you need to be made aware of the principle of hierarchy of pain, a term coined by my wife Kathleen. What this refers to is a seemingly innate response of the brain to warn you of the most painful site, but immediately after successful treatment of that site, the patient is likely to identify another site, which may be local to the first site or at some distance. I first became aware of the phenomena after injecting the right arm of a patient, and then immediately he complained of pain in his left arm. So, close identification of exact sites is critical, and all subsequent follow-up visits need to refer to that or those exact sites. I have come to learn that our minds work in a similar way for all those burdens that trouble us. Solve the worst, and the next comes right into view. I propose that prolonged, untreated, acquired muscle spasm causes ischemic changes resulting in membrane and or motor neuron instability, resulting in an arrhythmia in the form of SCA that not only identifies muscle and chronic spasm, but is a continuous stimulation for persistent spasm. I've identified this as the black hole of skeletal muscle pathophysiology. Once the muscle goes into true chronic spasm with SCA, there is no way to relax the muscle without resolving the SCA. I had trademarked my procedure so that it should not be ultimately confused with other EMG-guided procedures. CMECD is an acronym for COLETTI Method EMG-Guided Chemodenervation. I did not apply for a use patent, and none can be applied for, as the procedure was purposely placed in the public domain in my early abstract publications. In the U.S., phenoxybenzamine can be used off-label under FDA guidelines that simply require a scientific knowledge of its potential benefit, a patient consent that indicates that it is an off-label use, and keeping records of complications. The ability to relieve chronic pain without use of pain medication was immensely gratifying. As noted, I treated several hundred patients with the same protocol over the past 15 years. I was fortunate to have the trust of my patients to treat them with an experimental procedure, and enough data was retrospectively collected to support its efficacy. While a clinical trial would be ideal, it is possible to use this technique in office practice now under FDA guidelines. The website CMECD.info was put up as a physician teaching website and has a great deal of additional information, as well as the 2 articles published last year. Hopefully, with the information provided in this presentation and other materials available online, you'll be able to make use of your EMG device for therapeutic as well as diagnostic purposes. In summary, over the past 15 years or so, I've been learning how to use phenoxybenzamine with EMG guidance to treat chronic pain secondary to chronic muscle spasm. In the process, I've identified what I believe is the true cause of chronic muscle spasm, which is self-imposed ischemia of the muscle from untreated, potentially temporary muscle spasm. With the help of Hugo Carrero, I have proposed the existence of hibernating skeletal muscle to counter the concept of hibernating myocardium, as I've known in my field of interventional cardiology. I've also proposed a new interpretation of the cause of tendinitis, again as an ischemic etiology. Finally, with my wife's help, I have brought to light the concept of hierarchy of pain. All in all, I believe it has been a productive time well spent. I most enjoy the opportunity to present it to you, the audience, who I hope will take advantage and take up the bandwagon and relieve chronic pain for many. Thank you for your time and attention.